Good afternoon, everyone. This is Dr. Khalid Mateen. I am a medical oncologist at VCU Massey Cancer Center. I have focused on GI cancers and in particular colorectal cancers for about 20 years now since completing my training. Since this is March and Colorectal Cancer Awareness Month, it is obviously timely that we talk about colorectal cancer, and especially with a view towards screening and preventing cancers and how important that is. So I have a few slides here. We'll talk initially about the epidemiology, or how common colorectal cancers are, just to give you a rough idea of estimates that are from a few years back, but the numbers haven't really changed that much, is that it is the third most common cause of cancer-related mortality. We see about 135,000 cases a year in the United States and a little over 3,000 in the state of Virginia. Unfortunately, about 40% of people diagnosed with this cancer do die of their disease. So about 49,000 in the United States die from colorectal cancer, and a little over 1,000, and this is for every year that basically these numbers are valid. So what is colorectal cancer? But basically, it is a cancer of the lower bowel or the lower intestine or gastrointestinal tract. It is the most common GI malignancy. And after, lung cancer, it is the, second leading cause of cancer-related mortality overall, third leading cause in men, third leading cause in women. You can see the 5-year survival rate for early colon cancer that's confined to just the wall of the colon is 90% or higher. When the cancer is at a later stage, then the mortality goes down to about 40% when lymph nodes and other areas become involved. Anyone really is at risk for colorectal cancer. The older you get, the higher the risk. But the concerning finding has been that in the last couple of decades, we're seeing a rising trend amongst younger people getting colorectal cancer, about a 2 to 3% increase in people less than 50 as compared to the previous year. What are some of the things that can cause or prevent colorectal cancer? Here's listed that obviously a healthy diet prevents or lowers your risk. A lower BMI is beneficial. Physical activity is helpful, and certain other lifestyle indicators, such as smoking, can affect and have a not smoking is obviously what can prevent or reduce your risk. Things you should limit are processed foods and red meats, and sugary foods. Obviously, a higher BMI, controlling your weight. Less of this and more of these activities are preferred. And then reducing your consumption of alcoholic beverages. Cancer is a multi-step process. So it begins with an initial genetic mutation happening that causes the cell to become aberrant or abnormal, and it starts becoming malignant and it forgets how to die, basically. So that's why it keeps growing and spreading. But all of these steps are, they take years. And that's the intriguing part, that in colorectal cancer, you can, number one, can detect some of these changes happening, and we'll talk about that in screening. And also there are changes happening that can be visually seen in your colon that can that can have, consequences for preventing cancer. There is a genetic component to colorectal cancer, but the sizable portion of cancers are sporadic or average risk. But there are about 30% of cases, up to 30%, can be due to family history. The genetic conditions are somewhat rarer, but here they're listed. HNPCC or Lynch syndrome accounts for about 5%, and FAP is 1%, and other rare syndromes are less than 0.1%. Nevertheless, any family history of colorectal or other cancers should be conveyed to your provider so you can get the appropriate screening at the right age. As mentioned previously, the earlier we diagnose, the better results we get for all stages. The cure rate is about 65%. For localized cancers that are just in the wall, not spread to the lymph nodes yet, 90% cure rate. When its lymph nodes are involved, 71%. And for distant, if it's already spread to the liver or lung, then unfortunately only about a 1 in 10 of those patients will be cured of their cancer. Unfortunately, 90% of those patients will not be cured. Overall, death rates from colon cancer have been decreasing over the decades due to better treatments, more screenings, so earlier stage of diagnosis. So definitely compared to the 1970s, we're at a much lower rate for per 100,000 population. So there are improvements. Trends, according to, in terms of different ethnicities, we can see that certain age groups and certain ethnic populations are more predisposed. There's a higher incidence amongst the Black population, lower amongst white and Hispanics, and that holds true for males and for females both. The majority of cases that we do see, unfortunately, are at a stage 3, which is the one where the lymph nodes are involved. The earliest stage is about, stage 1 is only about 10%, stage 2 about 20%, stage 2 more like 25%, and stage 4 about 20%. These are the different stages. Stage 1 basically is when it's just invading into the superficial part of the wall. Stage 2 is when it goes deeper into the wall, but the lymph nodes are not yet involved. Stage 3 is when lymph nodes are involved. And stage 4 is when other organs get involved. And as you can see, the 5-year survival or cure rates changes dramatically as we go down from over 90% for stage 1, here for stage 2s, then stage 3s. There's a big drop when the lymph nodes become involved, and an even more bigger drop when, of course, it metastasizes to other areas. Some of the risk factors are age greater than 50, family history, being African American. That's why this population certainly needs to be targeted in terms of screening programs to improve the screening rates. Genetic conditions are here, pre-existing conditions. So if you had inflammatory bowel disease or prior colorectal cancer, you're at higher risk, as well as radiation to the pelvic area and these other conditions as well. Lifestyle factors that can contribute, people who are, decreased exercise. Other factors that have been alluded to, although not conclusively proven, are things like decreased folic acid. Aspirin use can potentially improve your chances, although again has not been validated. Calcium and vitamin D probably has a stronger role in preventing colon cancer. Increased fiber, increased calcium. Oh, sorry, let me go back. And garlic consumption. But again, these are not all proven. Some that have been validated better, like calcium and vitamin D and exercise, others not so much. Red meats and smoking and obesity certainly have been validated in terms of increasing your risk of colorectal cancer. So when we stack these things together, and this is just for all cancers, not just for colorectal, we can see really how much of a impact obviously smoking has clearly. But even being overweight, obese, lack of exercise, all of these things combined can really have a significant effect on one's risk of cancer. And actually, colorectal cancer is one of those cancers where there is a strong association between being overweight and your risk of cancer as compared to some of the other cancers. And that's really what's shown on this slide, is that there's convincing data that, reducing your weight, controlling your weight can reduce your risk of developing that particular cancer. It's not as strongly correlated in the other cancers. So prevention strategies, some of these things we touched on, diet low in alcohol, red meat, processed foods, higher amount of fruits and vegetable, maintenance of vitamin D and calcium, and then maintaining normal body weight and increased physical activity. Aspirin use, somewhat controversial, still undergoing more studies, as to is COX-2 inhibitors, which are non-inflammatory agents like celecoxib or Celebrex. We're awaiting further data from this trial, looking to see if there's any benefit in this setting or not. So let's touch on probably the most important topic today, which is screening, which basically by definition means when you don't have any symptoms. And I want that to be very clear, is that if you're having blood in your stool or other concerning symptoms, then it's a diagnostic test. It's not a screening test. Screening means that you are totally asymptomatic, no problems, but because the data shows that at a particular age, there is benefit to you getting screened, you get that procedure done. So you don't wait for symptoms to happen. Screening rates vary state by state. As you can see, we're kind of in the middle. We don't do as well as some of our neighbors in the Northeast and the Midwest, which have higher screening rates. But we certainly have room for improvement, and we have been getting better. So as you can see, this was data from a couple of years ago, showing us at about 70%, and latest figures show that we are at or about 80% for the state of Virginia, which is good, but we certainly want to get as close to 100% as possible for those patients. And really, these were about achieving some of these targets that we have now gotten close to. And by doing a lot more screenings, this is really how many cancer deaths and cancers that we can prevent. So I think that's why it's important that we as a community, and it's not going to be just one group, but really all these different groups that can come together to make cancer screening happen by working together as a community. These are some of the guidelines. Now, this is an older slide, so it says beginning at age 40. As you're probably aware, the new guidelines, recommend screening at the age of 45 for those who are average risk. If you have a higher risk because of genetic factors or family history, then you talk to your doctor, you potentially will start earlier. But for everyone else with average risk right now, it is 45 is the recommended age, not 50. So these are the modalities that are available. I think it's important to realize that you don't have to stick with one particular modality. And while colonoscopy is kind of the gold standard for visualizing and screening, it's not the only test that can be done. So if anyone has concerns about getting a colonoscopy, they should at least start with the stool tests that are the least invasive, and get either the FOBT or preferably the FIT, the fecal immunochemical testing, which is the most sensitive. There's also a stool DNA test, which interestingly looks at some of those DNA changes that happen. The steps I was showing earlier with different steps of the cancer developing, where it becomes initially a growth, a polyp, and then a cancer. Some of those DNA changes can be detected in this test. So it's a pretty neat test, and it is an option. Now, the only thing I will tell you is if you get one of these stool-based tests, and if it's positive, then the next step is going to be colonoscopy. So patients who get this have to be prepared to get one of these invasive tests done, because ultimately that's going to be required if you get a positive test. But it will be reassuring if you get a stool-based test and it's negative, at least you have done one form of colorectal cancer screening, which is still better than not doing anything. So I don't think we should get stuck on colonoscopies, and these other tests are a viable option as well. But know that if you have a positive test, then you will need a colonoscopy to investigate further. So really, colonoscopy is generally good for 10 years, as long as it's negative, no abnormal findings were found. The fecal immunochemical testing has to be done every year. But still, non-invasive tests, easy to do. And for some people who either don't want a colonoscopy for whatever reason, it's still fine and actually better to at least get a FIT test done every year as opposed to not doing any kind of screening. Key thing is to adhere to the recommendations. If you're doing colonoscopy, you want to have a good bowel prep, and you want to make sure you're getting it done with the providers who are experienced in doing that. I think it's important that we have patient navigation, which we have at VCU, is that as we get positive tests, we want to make sure those patients aren't forgotten. So any program needs to make sure that we then get those patients with a positive test hooked up to the right individuals and take care of that, because it's not a matter of just doing the screening and going home after that. One important measure is the adenoma detection rate. So these are measures that we use to assess if the people who are doing the colonoscopies are doing them adequately, and they're getting rates that reflect the population. So some things that we look at as a quality measure. Patients do prefer home stool testing, and that's why FIT testing is absolutely fine. And I always tell other providers that we should mention the whole array of the colon cancer screening tests, and not just stick with colonoscopy by itself. And as you can see, compliance in this community here was much higher for stool-based testing. And sometimes when you combine that with colonoscopy for a positive test, you get much higher compliance. This is the stool-based test, that we talk about. And the point I was making earlier, some patients may forego any testing if you don't talk to them about stool testing. And then at least you kind of put your foot in the door. You at least get them to start thinking about colon cancer screening by doing this. As I was mentioning earlier, FIT or fecal immunochemical testing is now the standard for stool-based testing, detecting blood, because it's superior to FOBT testing, which was the old stool test that was done, and is a test that we recommend for those people who are going to have this test done. It's basically more sensitive because it's dependent on immunochemical detection of the hemoglobin molecule as an indicator of blood, so it won't get false positives for other things. And it's more user-friendly, frankly. It comes in this very easy-to-use packaging where a stool sample is put in, and you are able to mail this home or bring it in. And the stool testing has to be done at home. So patient walks home with the kit and does the testing and mails it in. So I think it's easy to do and gives you a starting point and getting people in the door. So here basically is just some of the pros and cons of testing. Obviously a colonoscopy, it's the most thorough test there is, examines the entire colon and the rectum. And of course, if you have an abnormality like a polyp, you can remove it at that time. And remember that polyps are what become cancer down the road. So that's what the neat thing about colon cancer screening is that if you're developing signs of a cancer or developing a growth that can become a cancer down the road, by getting screening, you're actually removing and preventing that cancer from developing before it's developed. So if you think about it, it's a really, really neat way of preventing cancer, which is unlike screening for other cancers. We don't get that benefit with PSAs or mammograms. So yes, it is an invasive test, and that's why it's not right for everyone. But that's the benefit, as I mentioned, for getting a colon cancer screening. And if you get a negative one, you're done for 10 years. You don't have to repeat it unless, of course, you develop any new symptoms. So there are downsides. It does require a bowel prep. It is invasive. It is expensive. There can sadly be some complications like bleeding and otherwise. But it's like with everything, those are the pros and cons. So I think everyone needs to sit down with their provider and talk it through and see if that's the right screening test for them as well. Other tests, there is a CT scan available called a virtual colonoscopy, which is very dependent on the person doing the read. So it's not something that we routinely recommend. There's barium enemas and there's flex sig, which is basically just looking at the lower portion of your colon. Obviously, with both these radiology tests, if an abnormality is detected, you're going to need to get a colonoscopy. With the flex sig, you're only looking at the lower third of the colon. The upper 2/3 you are going to miss. But this can be, the flex sig can be combined with the fecal, the stool testing for better, higher yield. The stool-based testing, much cheaper, much easier to do. And like I said, for those people who are not ready to get a colonoscopy, I absolutely recommend starting off with this. So at least you're getting a test done and a negative test, reassured, positive, then you need to consider a colonoscopy. Well, what is the benefit? These are the number of lives that can be saved by doing FIT testing every year or FOBT testing every year, or a flex sig combined with the FIT testing, as I mentioned just a couple of minutes ago, or doing a colonoscopy every 10 years. So for all of these, these are the cancers you can potentially, out of 1,000 people that you screen, these are the lives you can save, cancer deaths that are averted. So that gives you an idea of the magnitude of what the benefit of this is to us as a community. Just want to touch base on overall cancer treatment. This is more for advanced cancer, which we are hoping to prevent, right? As we screen more people, we're hoping to prevent cancers or pick them up early before they become stage 3 or stage 4. Just for you all to know, the cancer treatments have come a long way in the last couple of decades. And as opposed to, previously when we only had like one active drug where the average survival was only about 10 to 12 months, now we're pushing 2.5 to 3 years for patients with advanced cancer. This is stage 4 colorectal cancer who are living. So if the average is 2.5 to 3 years, we actually routinely have some patients who are 4 or 5 years out with metastatic cancer who are still getting treatment and doing well and have a good quality of life. So things have changed, and it's always good to get a second opinion regarding your cancer, and also look for clinical trial options, because that's the only way we're going to advance cancer treatment in colorectal or any other cancer. And so I'm really proud that we have a couple of innovative clinical trials available and open at VCU Massey, looking at the addition of immunotherapy in the right setting for these patients with metastatic colorectal cancer that have particular predilection or a better chance of responding to immunotherapy. That's a study that's open for the metastatic setting, and this is an earlier stage study for patients who have stage 3 disease who get immunotherapy along with regular chemotherapy. And I think that's all I had for today, and really would encourage everyone to spread the word about colon cancer screening. Remember, 45 years or higher, make sure you talk to your doctor. And if you have a family history, even more important that you talk to your doctor about getting screened. And remember, screening is before you're having any problems, when you hit that age, whatever the guidelines say for you regarding your risk. And all options are on the table. It doesn't have to be colonoscopy, although colonoscopy is preferred, but other screening modalities are there. So make sure you talk to your provider. Have a good day.